Primary care management is the flagship skill of the general practitioner. It is what makes a GP different from an hospital doctor. It is the reason why when a patient is seen in the hospital, they are still sent back to their GP. It's because of primary care management. No other specialty has that skill. So would it not be fitting to test this skill in the general practice final exam to become a GP? And it's a problem area for me. It's the management of the whole patient rather than the disease alone. Good afternoon, everyone. Welcome to the 5th of our series of lectures. I hope you've enjoyed it so far. For those of us that are joining us for the first time, my name is Olaoluwa Fajimi. I'm a portfolio GP and a TPD in the Coventry and Warwickshire scheme. So we have done the first class, which is the introductory class. And then we did a second class, which is the structure class, and the third one, which looked at taking a focused history, and the fourth one, which looked at interpersonal skills, and we'll be rounding things up today with shared management. And today's learning objectives is that one, to understand shared management, and to understand why it's important, to know exactly how we do shared management, and to know what we have all been doing wrong, and most importantly, to go home with a clear knowledge of how to share our management going forward. So, we are expected to assume the clinical risks as GPs. Many of you know that we take several tens of decisions every blessed day. So after we've taken a focus history and we've done a clinical examination, we form a set of differential diagnoses, and they can range really from nothing really happening to something terribly bad. And most of the times, it's something in between those two extremes. And the thought of getting it wrong is always there. And I'm sure many of you sometimes go home thinking, oh, that patient should have done this, should have done that. And these thoughts, can cause a lot of anxiety among clinicians. So the point of shared management is to help us to share that decisions on management and to empower our patients to be part of this decision-making process, such that we are helping the patient make a decision rather than dictating to them what should be done. Shared management comes with some myth that number one, that clinicians are fully responsible. Clinicians or doctors know best, and the doctor is high up there. That yes, I have got to do this management to show to the examiner what stuff I'm made of, to make it clear to the examiner that I know what I'm talking about. And many times we also live under delusion that doctors don't know much about their health and their life, and those are not true. Of course, we know that they know. The dilemmas of shared management is people saying, how do I work such that I'm a team member in the patient-doctor relationship, and at the same time assume the role of the facilitator of the consultation at the same time? How do I share management in the face of safety concerns? For instance, when a patient needs to go to the hospital and I'm giving them an option of they don't have to go to the hospital, would that be safe? How would an hospital doctor manage a case versus how a GP would? And options in the face of no options, really. So, on what foundation does shared management sit? And one is that we are experts in medicine. We know our medicine. But second is the fact that patients are experts in their own health and their own life as well. they know about their health and about their life more than we know. And we do not know as much about their health and life as much as we think we do. So the point is that we use each person's strength in terms of the areas of strength of the doctor being the expert in medicine and areas of strength of the patient being the expert in their own health to form a synergistic approach to their management. Why do we then share management? First is to make the patients involved. We know that when they are involved, they will be happier. We know when they are happier, there will be less complaints. It gives the opportunity not just to treat the disease, but to treat the complete human. It gives us an opportunity at an holistic approach, and it allows us to properly manage the risk. And the patient themselves can see our decision-making process such that they understand what we are going through in terms of making a decision. When we are saying to patient that, oh, I think this is what is happening, but it could yet be this. How about let us do a trial of this treatment and see if it makes any difference. If it doesn't, then perhaps it's that other disease condition. So they can see our problems, they can see our troubles because we have shared it with them, and as such are more likely to empathize with us, are more likely to from a point of view of understanding our thought process, to see when things don't go the way we like it to go, they can appreciate a little bit more what the challenges are. So what are the elements that we are going to be focusing on? This time around, I've left this teaching as it is rather than going by the marking themes of the RCGP, because these themes will cover a lot of, in fact, it covers every single thing in the marking themes of the RCGP as far as the SCA is concerned. So number one is the attitude and the posture to shared management in terms of getting the words and the phraseologies right, management options and acknowledgements and respects for patients' preferences. The others are the management itself, which includes the primary care management, which we'll do a lot of talking about, and the clinical management, health education, follow-up, and safety netting. So we'll start with the first one, which is the attitude and posture of shared management. Think about this. When you're talking to a child and the balance of power tilts heavily towards you, there is a posture you have. But when you're talking to a partner that you share the balance of power together, that the balance of power is well balanced, there is a posture as well. Now, look at that second example and the posture you would have in that situation. That's the same posture we need in terms of our patient-doctor relationship when it comes to shared management. So we have that posture that I'm not in here to lord it over my patient. I'm in here to, as the expert in medicine, to present the medical fact whilst letting them present the fact from the patient as the expert in the patient, and then both of us at the same time look for a middle ground, such that the mode you're in is a negotiating mode. You're not in a dismissing mode. Oh, I don't want to go to the hospital, doctor. So why don't you want to go to the hospital? Tell me. Rather than, oh, I see you don't want to go to the hospital, but is there any particular reason why? Trying to explore why and trying to reach a middle ground. So it's a problem area for many of us in terms of the attitude to the shared management itself, because clearly many of us have come from a different background where the medical doctrine is completely different from what the doctrine is in the UK, where it is still a doctor knows it all doctrine. So, and that's a big problem because we are coming into a completely different environment now, where things are done different from what we are used to. And as I always say, if one hasn't been practicing that with their day-to-day patient, if one has been high-handed and bossy to their patients, they are not going to do any different in the exam. They may role play, but after a few stations, the real doctor, the real person will come out and they'll be back to their bossy style. They'll be back to their high-handed behavior. So it's something we need to practice first with our colleagues at work, second with our patient at work, such that we then bring that to our role play. And it's a behavior that even when we are pushed, it is still the same behavior we maintain. In terms of the words and the phraseologies, it's a we word. How about we do this? Not I, not my. It's one thing to have the right attitude, but it's one thing for your words and your phraseologies to match the attitude you're projecting. So if you've got the right attitude, but your words are still saying, yeah, what I'm going to do is to send you straight to the hospital. Is that all right? That's not going to fly. So you not just need the attitude, you also need the words to match the attitude you're projecting. The whole of you needs to use the words, even though the words are coming from your mouth, but your face, your attitude, your predisposition, everything needs to be in keeping with that. So we could consider sending you into the hospital, especially as your numbers are not very good. What are your thoughts about that? Something else we could do is this. What do you think about that? Another thing that comes to mind is perhaps to run a couple of blood tests. Is that something you're happy for us to do? So those are the words and phraseologies you want to be using in terms of your primary phrases and the one after. Is that something you would like to look into? Is that something you wouldn't mind trying? Is that okay with you? Are you happy with that? Does that sound like something you're okay with? And those are phrases saying to you that I'm not making the decision. I, as the expert in medicine, have given my expert opinion, but now I want our panel, which is the product of the patient-doctor relationship, to then deliberate on this expert opinion to decide what is the way forward for the patient. Imagine me saying, Mr. Smith, you've got a chest infection, you're a bit confused, your numbers are not good, you're going straight into the hospital. I'm just going to call the medical team now to inform them that you're coming. Those are two very, very different things. So these are the ways we need to be communicating in terms of our management to show that it's not just our opinion, but we are sharing them. There are words we need to be careful with. And many of these words are words that many of us have used in our day-to-day life for many years that have become part of us. Okay? All right? Those are condescending and commanding words, irrespective of how we try to put them. I know many of us have worked on ourselves such that those words don't come across as condescending and commanding, but at the same time, we are better with those we discussed earlier. If any of us need to write those down, perhaps I wait a couple of, if you just mention on the chat, so I wait a minute or two to write them down if anyone needs to. Otherwise, I will assume no one needs to. I'll just proceed. Does anyone need to write those down now? All right then. In that case, let's carry on. So and things like, what I want is this and this. I'm sending you to the hospital. I hear that a lot. I'm sending you to the hospital. What I want you to do is this and this. What? No. That's not how it should be done. Second is options. Options show your wide knowledge range. They also demonstrate that you're not dictating to the patient, and they demonstrate that you're providing good service to the patient. They demonstrate an effort on the part of the doctor to tailor the management to the needs of the patient, and they demonstrate that the patient is indeed respected such that they are given many options. And we could start with, there are a couple of things we can do here. A few things come to mind. There are things you could do, and there are things we could do for you. Which would you like to hear first? And the option versus safety is in the context of a lot of people who have raised concerns about, say, patient needs to be admitted into the hospital, for instance. And how do you give option in that case? So you could give option, but then lead on the option. Well, Mr. Smith, because your numbers are bad, they are not what we would like, you're a bit confused, you've got a chest infection. If we treated these with oral antibiotics, with antibiotics at home, things are likely to get worse. But there is a better option, I think, which is to consider sending you to the hospital for IV, for antibiotics into your veins. You've mentioned the option of oral antibiotics. You've mentioned it in person. But you've told the patient clearly that because of X, Y, and Z, not because that's how we do it. No, not because in this situation, this is what we do. No, but you've explained the reason why to the patient. And that's option with direction. You've noticed that that's a safety concern, that if you were to give an open option, the patient may say, well then, doctor, since that's an option, give me the amoxicillin, I will take it at home, knowing that the patient is likely to deteriorate at home. So you've mentioned the option, but you've led them to what the best option is with facts that you have gathered in the body of the history. So that's how to go about that. Third is acknowledgement. Acknowledgement is you bringing back the expressed expectations when you were doing your eyes, the expectations that the patient has expressed, to bring them back and acknowledge them. I mean, Mr. Jones, I fully recognize that you would like to be referred to the dermatologist for this acne. But looking at the acne, it's something really that we should be treating in here, to be honest, because I'm looking at it now. There are no scars on your face. It does come across as a mild to moderate acne, which is something we can pretty much treat. If we were to attempt treatment, however, and things don't go the way we like, or things get worse such that you now begin to get scarring, then we are more than happy to refer you as you've requested. Is that all right? So what you've done is that you fully appreciate their preference and their expectation. They want to be referred. You put that into consideration. You brought that forward, and you've used your expert opinion and knowledge to say, look, this might not be the best option here. But if they've given a safe option and the right option, then go with it. Oh, Mr. Jones, I perfectly agree with you in here that you need a referral because there are some scars in here, really. And the fact that we've tried a lot of the initial options in the past, and they haven't really helped us. So on that ground, I will agree to do a referral for us. Is that something you're happy for me to go ahead and do? So you're acknowledging it and you're going with it because it's the safe and the right option. But if unsafe, you provide alternatives. Like in that first example, the patient wanted the referral, and I've gone, it hasn't got to that stage. Let's treat. And then you negotiate and find a middle ground. And I've then gone ahead to say, look, if we trade and we don't get what we want, referral is something we can consider after. And it is that negotiation the examiners want to see. Not, no, 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 Mr. George Jones, I'm afraid I am not referring you. What I will do for you is to give you some cream, and then you can see me after 12 weeks. That's not going to fly, and we won't get our full marks if we do that. So the next is the clinical management itself. And I will spend a lot of time on explaining to us what primary care management is, because I know that many of us have hospital backgrounds, and we are still pretty much hospital doctors rather than GPs. Primary care management is the flagship skill of the general practitioner. It is what makes a GP different from an hospital doctor. It is the reason why when a patient is seen in the hospital, they are still sent back to their GP. It's because of primary care management. No other specialty has that skill. And so would it not be fitting to test this skill in the general practice final exam to become a GP? I think it's absolutely the right thing to do, and it's a problem area for many IMGs, not because we're IMGs really, but it's because we're IMGs who also have mainly hospital backgrounds. That's the reason why. It's the management of the whole body, of the whole patient, rather than the disease alone. It usually starts with a focused history, as we described in the last teaching. If you haven't seen it, please do well to see it. If possible, play it multiple times till it becomes second nature to you. We haven't done that, and we haven't taken the relevant social information from the patient. So we're managing things we haven't established. It's no different from building a beautiful house, but in the air it's not going to stand because we have not established the foundation for it. So think about each component and then manage them. This headache, ask the patient from the history as we've described. Has it affected them at home? Has it affected them at work? How about their relationships? Has it affected themselves, their mental health? Has it affected them? Think about that. Think about the quality of life in terms of the mobility. How have they been able to move at home and move to work and go to the shopping areas to get their groceries? Has it affected their finances? If they can't walk, if they've got a chronic illness, for instance, and they can't walk for months, it's only logical that we ask about their finances. They are coughing all the time. It's only logical we ask if the cough won't make them sleep. If they are being sick all the time, it's only logical we ask about their eating and drinking. If they're acutely unwell, it's only logical we ask whether they've been eating and drinking okay. Has it affected the activities of daily living? If someone has got a diagnosis of Parkinsonism, for instance, it's fair and square that we're asking about the activities of daily living. Are they doing the dishes? Are they making their food? Those are rights and absolutely the right thing to ask. The challenge many of us face is that we do not ask all these important questions in the history, only to then manage them. So what then would we be managing? So because we've not asked in the history, we're unable to then transition effortlessly such that our consultation are fluid and smooth. Oh, Mr. Smith, you mentioned your struggle about finances. What are your thoughts about involving the social prescribers here? You know, because we haven't asked. Okay, so of course, each of those are the general ones we need to ask only when appropriate and when relevant. if someone has got uh, 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 um, say they've got a dental abscess, for instance, and then I begin to ask them about how 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 they are able to do the activities at home. It, it may not be well suited for it, so it must be appropriate. It must be relevant. It must be timely as well. But also we have to mention it as well. For instance, in terms of their social history, if someone has got stroke and we're asking them about smoking and drinking, it's fair and square. But someone has come with acute appendicitis and they should be on their way to the surgical team, and then I'm worried about how many sticks of cigarette he has been smoking. I mean, no examiner will take me seriously. So, except if it's such that the lifestyle has directly led to the disease or it's playing a significant role in it. So those are important to ask, but it's important they are relevant as well. The social context of alcohol, of smoking, of recreational drugs, of exercise, each of them will need to be addressed as appropriate. And we need to know exactly what is recommended, explore what has been tried before, explore if things have been attempted and they've failed before. It's not we often say not to smoke. No, we need to be telling them specific. We are scientists, so we need to be telling them the specific reasons why they do not, why they should not. Or smoking has been found to put you at risk of a stroke or a heart attack. That's better than we always ask, do you smoke? No, always ask is not a statement of a professional, and we are doing all those in a non-judgmental way such that the patient doesn't feel judged for their choices, but they are able to appreciate where we are coming from as the professionals, with us explaining the reason why to them. And when you hear someone say there are things you can do yourself and there are things we can do for you, those things you can do yourself, they are referring to the primary care management bit of things. So we can use the primary care management as an option. And even inside the primary care management as well, there are still options we can give. Well, Mr. Smith, in terms of the things you can do for yourself, when we discussed, you mentioned about drinking 2 bottles of wine every night, and you mentioned about smoking as well. But you also did mention about your struggles with mobility in the house. Which would you want us to address first? So you can still give option even within options, such that you're not giving orders. You're not saying, Mr. Smith, you need to smoke. You need to stop smoking. Stop using that recreational drugs. We are doctors. We are not army generals. Third is the clinical management, and this is where many of us do well, because it's the territory we are used to. It's the territory we know well, and it's where doctors do well. But doctors who haven't inculcated what the skills of a GP is are, they are caught here as well, because they cannot give options for starters. Number two, they do not know what the current guidelines are. One of the top reasons people fail in this area, if you check the marketing themes, is that doctor did not give management in line with current guidelines. So know the right management for every condition possible. Know what the first line is, know when the second line is, know when to refer, know when to refer through through 2 weeks wait, for instance, when you will routinely refer, when you'll be sending them in on the same day, know all those medication, know the first line, know the second line, know the side effect of the medication as well. If unsure, acknowledge it. Don't pretend you didn't hear when the patient asks, so what are the side effects, doctor? Acknowledge. Unfortunately, it's not something I can remember now at the top of my head. However, the pharmacist is going to give you some they will dispense the medication with a leaflet. You could have a read at the leaflet, and if you then have any questions following that, you could let us know. Give options in here. We've got a few options. As we've got a few options. As most of these things can resolve on their own, so we can decide to watch and see, or we can decide to treat. Which of the options would you rather go for now? And then we use our phrases as we've described. And again, no orders, no instructions. Is just us trying to be equal partners with the patient. The next will be health education. So those perspective that's been expressed. Oh, doctor, it all started in my throat. You see that cough, but right now it's gone straight into my chest and it has formed the chest infection. You see, I need antibiotics right now. Well, I know you did mention how it all started from the throat and is now gone to the chest to form a chest infection. I've listened to your chest and thankfully your chest is clear. Look, Mr. Jones, this isn't a chest infection, really. This is a viral upper respiratory tract infection because of X, Y, and Z reasons. So you have explained that without you going, no, Mr. Jones, you don't understand medicine. That's not how it is. This is how it is. No, you don't want that. Give leaflets as appropriate. If you're giving leaflets, mention the leaflets you're giving. Oh, we're going to give you some head injury with written advice to help you understand what's happening. Well, I'm going to give you some leaflets on lifestyle changes in terms of diet and exercise that we need in hypertension. So express exactly and specifically what type of leaflet you're giving and explain the reason for the medication. Again, we usually give this, will not do it. It's not going to do it, or because there is a chest infection ongoing. I think it's important for us to consider some antibiotics in here just to make sure things don't progress and that bug is well looked after. What are your thoughts about that, Michelle? So what you're saying is that you've expressed the reason why you're giving it. So explain what may happen after. Usually with a chest infection, it can take up to 6 weeks for it to resolve. The last symptom we usually expect to resolve will be cough. So if the cough is still there and getting worse after 6 weeks, so please come back to us. So they know exactly what they should be expecting and what are the self-help measures you could give with the symptoms. So next is follow-up. Again, follow-up is an area a lot of people or a lot of us believe we know, but we actually do not. So we need to explain when next we'll be seeing the patient. The patient needs to leave a consultation room certain of what's going to happen next. And in the next one, in the follow-up, we want to, when we are deviating from standard, we want to bring the mitigating circumstances into account. Well, ideally, we like to see you after so time, but because this acne is is almost getting to the severe category, perhaps we see in about 6 weeks. So come to think of it, you see a diabetic now and you've started them on metformin. When would you see them again? What's the follow-up? You see someone with pyelonephritis, what is the follow-up date for pyelonephritis? We can mention in the chat. Pneumonia, for instance, you've seen, when would you follow them up? Would you even follow them up at all? Acne, when would you follow them up? Think about that. And each of those conditions, many more, there are set guidelines on when you should be, on when we should be following them up. And when those deviate from standard for circumstances we have presented in front of us, then we should be taking that into account and explaining that that's why we are seeing them sooner, or we are seeing them longer than what the guidelines have suggested. So in clear terms and terms, we want to explain when the patient needs to come back to us sooner. There is a, yeah, acne, yeah, absolutely. 12 weeks. 12 weeks is acne. Okay. Pyelonephritis, anyone? Anyone? Let me see the chat. Yeah. Pyelonephritis is 48 hours, 2 days. 2 days, pyelonephritis, 2 days. So for everyone, and that's how to go through the guidelines. That's how to study for this exam. You look at the condition, you look at how to define the condition, you look at what are the choices of investigation of it, you look at what's the first line and second line management, and you look at the follow-up, what's the time you'll be seeing them. That's so important. Okay. And anyone else in terms of, just a minute, pneumonia, diabetes? Think about this. Safety netting. So we want to explain clearly when the patient needs to come back. Oh, if it's getting worse, come back. That's not going to fly this exam. We need to let them know what they need to see that will make them come back earlier than the usual follow-up time, which we have described to them. And the safety netting will need to be known and established implications of what we've said the diagnosis is, or what we've said the working hypothesis is. I cannot see someone with migraine, a 21-year-old, and I'm telling them, and I'm painting a picture of stroke, and I'm saying, oh, if you've got limb weakness, you're drooling saliva, then please come back. What I'm saying to them is never come back, because that will never happen to them, and so they will not come back. So it has to be safety netting, real safety netting, not not the safety netting I haven't thought about. No. If someone has got a UTI, for instance, the reasonable safety netting of that will be me painting the picture of pyelonephritis for them. They've got pyelonephritis. A reasonable one will be me painting a picture of sepsis for them, because that's a known and established complication of that. But if I'm saying a child has got a viral illness, they've got every symptoms in the textbook that is viral, and then tell the parent that if they've seen a non-blanching rash, then they should come back. That will be completely unreasonable. Again, we want to avoid sending everything to A&E. Oh, things I was go to A&E. No, we want to know under what circumstances should they go to A&E. Someone has got low back pain. Under the circumstances of what or features of caudal equina, we're asking them to go to A&E. Fair thing to do. Fair thing to do. But at the same time, we are saying, but if they're not getting that symptoms, but the painkiller we are giving them is not helping, or the exercise we are giving them is not yielding much result, then they should come back to us rather than everything go to A&E. A lot of us have mentioned Getting feedback from the examiners that we are risk averse. That's the reason why. That's the reason why. If you've got a chest infection, we are giving you antibiotics. If it gets worse, go to A&E, and the patient can't sleep all night. And then in the morning, they go straight to A&E. Why have you come to A&E? I couldn't sleep all night. Doctor said if it's worse, to go straight to A&E. So we need to define exactly, we need to define the terms very clearly. In summary, let's focus on primary care management. Let's look at our time well. If we look at our time and there are clinical management things we haven't discussed and we're running out of time, then we should discuss the clinical management things first, whilst saying that because of the smoking you've told me about, because you're struggling with finances, because could we discuss all these specific details at a later time? You are acknowledging that's important, and the examiners can hear that you acknowledge it, that you recognize is an important thing. That if it was an ideal, well, it's not ideal, but if it was in another situation where you had all the time in the world, you were still going to address them. So many of us, we've acquired all sorts of bad habits in our careers, and a lot of these habits need us to take a lot of time unlearning them and relearning what is time. And we won't unlearn them when we constantly find ourselves in the midst of people with similar bad habits. All that will do is to reinforce those bad habits for us, and then we then wonder when the exams don't go how we like it. We then wonder why. It's because we've had all our bad habits reinforced by people with similar bad habits as well. As we say, a lot of practice. And what are we practicing? Practice using your phraseologies. Use them as we've described. Practice them till they become second nature, such that whoever is seeing you is not getting the vibes that you're acting, but they are getting the vibes that, oh, this is how this doctor is normally. This is how they conduct their consults normally. And then the second thing you're practicing is practice how to give option. And the third thing is, at the beginning of your management, learn to use your transition statement. Transition smoothly, like a plane landing, land smoothly. Well, there are a couple of things we can do concerning this this infection, Mrs. Smith. So you've not said, so yes, we are now in management. No, you don't want that. Transition smoothly to it, such that it comes like a good communication and it just flows seamlessly and is so smooth and fluid that before the examiners know what's happening to them, you've taken your full marks before they even notice anything. You've taken your full marks, and that's what we want. Thank you so very much.